my name is Dr. Anozie. I'm going to talk about AutoPEEP today and some of the detrimental effects and how it can be detrimental for your patients that are mechanically ventilated. And to get this started, first I will show a little bit of a ventilator waveform. And this is a clinical scenario. You have a patient that's kind of hemodynamically unstable, heart rate's 111, blood pressure's on the lower side. And on the left, you can see respiratory acidosis. pH is pretty acidotic with a high PCO2, hypercapnic, and borderline hypoxemic. So this is the ventilator waveform. This is actively recorded in the patient that we did take care of in our ICU. And then the question is, how do you want to adjust the ventilator towards the benefit of the patient? You can either increase the respiratory rate, the rate and tidal volume. The tidal volume, it's alone, or you can decrease the rate and the tidal volume and increase the tidal volume and the PEEP. So just giving everyone maybe just a couple of moments to just think about that. And then, so the best way to manipulate the ventilator in this situation would probably be to decrease the respiratory rate and the tidal volume. And the reason for that has everything to do with AutoPEEP. So what exactly is AutoPEEP? First, think about the physiology of a normal lung breath. At the end of a normal tidal breath, the lung reaches a relaxation state where the tendency to recoil inwards and the tendency of the chest wall to recoil outwards are at equilibrium, and that pressure in the respiratory system is typically zero. However, when there is AutoPEEP, that pressure is no longer zero. There is a positive, what you call inward static recoil pressure that becomes a hindrance to ventilation, as you'll see a little bit later on. It's also termed intrinsic PEEP or even occult PEEP because it's not very apparent unless you perform certain maneuvers or notice specific things that actually indicate the presence of AutoPEEP or intrinsic PEEP. And if left unchecked, can progressively lead to the dynamic hyperinflated state, which is really responsible for all the changes in lung mechanics and all the physiological derangements that you see in a lot of these patients that have AutoPEEP. Interestingly enough, AutoPEEP and dynamic hyperinflation are two terms that are often used synonymously or interchangeably, but it is possible to have AutoPEEP without dynamic hyperinflation. So diving deeper into this concept of dynamic hyperinflation, really the definition of that is exactly in the word. The lungs are hyperinflated because at the end of exhalation, the lungs fail to return to their relaxation volume. So the only way that can really happen is if exhalation or if the expiratory phase of ventilation is incomplete. If the expiratory phase of ventilation is incomplete, then the relaxation volume progressively rises, and that's what causes a lot of the physiological derangements. So take a look at this graph. It looks kind of convoluted, but this is really just a pressure volume curve with a bunch of things kind of highlighted and labeled. This is a sigmoid shape representing the lung at different volumes and their corresponding pressures. And in a patient who does not have dynamic hyperinflation, EELV would be the natural FRC, where the lung volumes are returning to their baseline state, and then this would be the end of inspiration. And then if you look at this red line here, you're seeing the progressive rise in end expiratory lung volume that is caused by AutoPEEP with progressive increase of PEEP. Here you can see from 0 to 7, which corresponds to an increase in your FRC and some of the physiological derangements that happen with that. So that's what we could refer to as a dynamic hyperinflated state that is related to AutoPEEP. Now, how does that occur? So we're going to start with the concept of an incomplete exhalation. So the lungs are not returning to their baseline state. And what are the factors, the main factors to be considered when that doesn't happen? And this is important because we need to delineate these two, because it's going to affect our management on how we're going to, how we're going to change the ventilator when we notice this in our patients. So on the one hand, is it because of reduced expiratory time, because of inappropriate vent settings that need to be altered, Or is it an intrinsic physiological derangement due to lung units with long time constants? What are long time constants? Long time constants are basically lung units that have high airway resistance or low airway compliance. So that impedes the expiratory flow for in one manner or the other, which we'll kind of take a look at. So with increased airway resistance, resistance is the direct competitor of flow. So as airway resistance increases, your inspiratory and your expiratory flow will subsequently drop. And with loss of elastic recoil, the pressure that the alveoli can generate to get airflow out of the lungs at the end of a tidal breath is also diminished. So I mentioned earlier, AutoPEEP does not necessarily coincide with dynamic hyperinflation in all states. So when we talk about AutoPEEP without dynamic hyperinflation, you're thinking about patients, and you've seen this before, we'll all see this when you have patients that are on mechanical ventilation, patients that really have highly active respiratory drives, probably patients that have metabolic derangements such as metabolic acidosis or sepsis or ARDS and have really highly active respiratory drives. And they're really, and you'll see this on the ventilator, and you'll see this by just directly observing the patients. They're working to bring air in, and they're really forcing air out. So much so that at the end of expiration, when the expiratory valve closes, they're still generating expiratory flow. So the fact that they're still generating expiratory flow, even though their lung volumes have reached pretty much the normal state, they're incurring a pressure gradient between the alveoli and the respiratory circuit that becomes interpreted as AutoPEEP and can result in some physiological derangements. So a little bit later on, we'll kind of see what a small example of what that kind of waveform looks like on ventilator graphics. So we mentioned some risk factors, like who are the patients that are going to develop AutoPEEP or who are liable to present with that physiology. Obviously, the most obvious would be patients with obstructive lung diseases like asthma and COPD. But for reasons that we mentioned before, sepsis or patients with neuromuscular disease that really have to work and exaggerate that muscular effort just to get air out, and same with ARDS. What are the consequences of AutoPEEP? It's not simply enough to just talk about AutoPEEP. We have to, if you really want to be able to make it a priority to mitigate these things, you need to understand the physiological consequences of what happens when a patient has pretty significant AutoPEEP. And the first thing we'll talk about here is increased work of breathing. Why does that happen? If we go back to this pressure volume curve, at the end of a normal tidal breath, this is a normal end inspiratory lung volume, and this triangular area corresponds to the elastic work of breathing for a patient to take in a tidal volume of 500 mLs from a normal FRC. Now, with AutoPEEP, as AutoPEEP tends to accumulate, you can see this triangular area starts to grow, and it becomes higher just at the normal or at the regular end expiratory lung volume for a patient that has hyperinflated lungs. So just with the increase in FRC alone, you incur an increased area for your work of breathing. And then starting from that new FRC to take in that same amount of tidal volume, this square shaded area, which is much larger than any of these triangular areas, that corresponds to the elastic work of breathing for a patient that is now essentially breathing on the less compliant portion of the pressure volume curve. Starting from here, you can see changes in pressure correspond with larger changes in volume. Small changes of pressure, large changes in volume. This is a steep portion of the pressure volume curve, but it starts to flatten out here. The lung is less compliant, and much more work needs to be done to attain the same tidal volume. Another thing to consider is ventilator-induced lung injury, most often barotrauma, because like we said, as a lung becomes hyperinflated, we're starting to approach this flatter portion of the pressure volume curve where lungs can easily get over distended and suffer lung stress just from already big and hyperinflated lungs. VQ abnormalities. When you think about ventilation perfusion abnormalities, what comes to mind is thinking about west zones of lungs. So the alveolar pressure is progressively rising because of incomplete exhalation and enlarged end expiratory lung volumes that incur larger end alveolar pressures. Now, in zone 1, there's great ventilation, but there's no good lung perfusion because the alveolar pressures are typically so high that they, compress the pulmonary arteries in the veins. So there's no perfusion. In zone 2, you start to get a little bit of perfusion and you start to get a little bit of gas exchange because you have a higher arterial pressure. And in zone 3, this is kind of where we all want to be. We all want to be in zone 3, where the arterial and venous pressure outweighs the alveolar pressure. But different physiological conditions can be created, such where the alveolar pressure in all zones of the lungs outweighs the arterial and the venous pressure. In that case, you'll have dead space ventilation, where you'll have good ventilation, but you won't have perfusion, and from that you'll have impaired gas exchange, and that causes VQ mismatching and progressive hypoxemia and hypercapnia. Hemodynamic collapse. So this is a big one because AutoPEEP, as mentioned in the title, can kill your patients. It can literally cause cardiovascular collapse, and it can do so pretty quickly. Why does this happen? Think about the rise in intrathoracic pressure. Now, the transmural pressure of the central veins, the pressure that keeps the central veins open so that they can return blood flow to the heart, would be the pressure inside the veins minus the pressure that surrounds the veins. The pressure surrounding the veins would be the pleural pressure. Now, as the pleural pressure rises with AutoPEEP, then your preload then falls because the transmural venous pressure continues to fall. And what tends to also happen with increased intrathoracic pressure is the ventricles tend to become a little stiffer, less compliant. They don't expand quite as well, so you don't get as much preload. So those are two things that are going to really kind of hinder your stroke volume and your cardiac output. That on top of the pulmonary vascular resistance, right? The right ventricular afterload tends to increase at higher intrathoracic pressures. And with the higher afterload, stroke volume falls and thereby cardiac output. Now, ineffective triggering. So ineffective triggering occurs in patients that fail to trigger the ventilator, actively breathing patients that fail to trigger the ventilator. And this tends to be very strongly associated with AutoPEEP. When you see this, you should suspect patients that have AutoPEEP. And then in this diagram here, this is where you see it. You see a patient that tries to trigger the ventilator but is not able to generate any flow. And this is because of AutoPEEP. And it's a sign that, some ventilator settings need to be adjusted. Why does this happen? So we mentioned before, when you have AutoPEEP, the relaxation pressure is no longer zero. There is now a static recoil pressure. So in this example, assuming that there is no AutoPEEP, then the patient only needs to generate a pressure of 2, of intrapleural pressure of -2 in order to trigger the ventilator. Now, with a static recoil pressure now on top of that -2, in this example here, the AutoPEEP progresses to about 7, which means that the patient no longer has to not only has to overcome that static recoil pressure, but then the trigger threshold on the ventilator just to generate a breath. That's a lot more work that the patient has to do. And quite frankly, a lot of patients simply can't do it because of the weakness of their that's been incurred by the weight of their illness. How do you detect AutoPEEP? It's not always easy. It's not always apparent, but probably the most, the easiest way, the most consistent way would be to look at your flow waveform and if you look at this dotted line, you can see this is what a normal patient should look like. And you see the flow waveform is returning to baseline before the next breath starts. In a patient with AutoPEEP, the flow waveform does not return to baseline before the next breath takes off. So that basically tells you that there is still some end expiratory flow to be had, that's not some end expiratory flow that's not getting out of the lungs before the next breath is starting. So that tells you that there could be a progressive rise in intrathoracic pressure just because there's still volume that needs to get out of the chest. Now, this can be misguided for several reasons. Number one, we talked about the concept of dynamic or auto-PEEP without dynamic hyperinflation. And those patients will look like this. You know, they'll breathe so hard that flow will return to baseline, and it'll be easy to assume that they don't have auto-PEEP. But they're breathing so fast, so these waveforms are coming in quick succession, even though the expiratory flow waveform is returning to baseline. And they're generating auto-PEEP, and quite frankly, a lot of these patients you'll see actually have some degree of hemodynamic collapse. Their blood pressure is on the lower side, they're tachycardic. And it's one thing to just kind of keep in mind when you're going through your algorithm on the ventilator on what can be wrong with these patients, you know, how to resuscitate them, and is it a resuscitation issue, or is there something else that we need to do to make the patient more comfortable so that they're not breathing as hard and creating so much auto-PEEP that could be hindering their hemodynamics. This also doesn't account for lung units with low compliance. When we talk about time constants, we talk about lung units with high air resistance and also low compliance. Poorly compliant lung units may not even be, their lung volumes at expiration may be so small that they're collapsed. It might be atelectatic lung that is not exhaling any gas. So you won't see that on this kind of a waveform. It'll still appear normal, even though there's auto-PEEP. So it can be misguided. Your plateau pressures. Now, we mentioned earlier that as dynamic hyperinflation progresses, you're starting to breathe at a less compliant portion of the pressure volume curve. So if the lungs are becoming less compliant, then higher alveolar pressures are going to be needed for distension. And that can be detected by doing an inspiratory hold, as you see here, and potentially seeing progressive rises in your plateau pressure. So looking at the plateau pressure just in and of itself doesn't tell you that there's, you know, auto-PEEP. But if once you've had a patient on the ventilator and you've kind of had some baseline parameters of what they initially look like on the ventilator, you know, if you're doing progressive checks and your plateau pressure seems to be progressively rising in combination with, you know, a patient who's no longer doing quite as well, they're hemodynamically maybe unstable, or they're developing hypoxemia and hypercapnia, it's something that you can definitely suspect. And then how do you actually measure the auto-PEEP? But this is going to be important for what we're going to talk about kind of in the following slides. But clinically, you know, probably the most efficient way would be to do an end expiratory hold and allow the pressures to equilibrate as volume as the airflow kind of equilibrates between lung units at when you hold the patient's breath at the end of expiration. Whereas the total PEEP in the system will be equal to the applied PEEP, which you set. And what you typically see is that there's auto-PEEP, this waveform will start to bump upwards. So then, if you have a total PEEP, if you subtract the applied PEEP, then that will give you the intrinsic PEEP, and you'll know that the intrinsic PEEP, you'll know what the intrinsic PEEP is simply from just making that simple calculation. So how do you reduce auto-PEEP? Reducing the minute ventilation. Reducing your respiratory rate provides a lot more expiratory time, allows more time for air to get out of the lungs and for the lungs to return back to their natural relaxation state, as well as minimizing your tidal volumes. So if you minimize your tidal volumes, then you minimize the amount of time it takes for breath to get in. So the higher the tidal volume you set, the more time it takes to get that breath in. But this also kind of speaks to the concept of permissive hypercapnia. And one thing I always like to say is that shooting for perfect numbers and shooting for that perfect pH and that perfect PCO2 is a perfect way to hurt a patient. You know, so we don't need to be doing that. What we need to do is give the patient what they need to survive. We don't need to give patients what they need to make their numbers look brilliant and perfect. We just need to be able to keep things nice and efficient so that patients have time to recover on their own. Optimizing the IE to ratio kind of plays into what we just discussed about, minimizing your tidal volumes and your respiratory rates. But if you're in a volume control mode, you can increase your flow rate. If you're on a pressure mode, you can reduce the I time so that you have more time for expiration. Bronchodilators, keeping the airways open and patent, because airways that are more constricted have a lot more resistance, and that'll impede your flow. Also, an ET tube size. Think about Poiseuille's law. So if the ET tube is smaller, then there'll be a lot more resistance, and that'll cause expiratory and inspiratory flow limitation. Clearing the secretions. The more secretions they are, it kind of narrows the lumen of the airway and increases the resistance and can cause flow limitation in both phases of the breath cycle. Optimizing your analogous sedation. This is very important. And the key word here is the analgesia. Making sure the patients are comfortable. Because if patients aren't comfortable on the ventilator, then they're going to breathe hard. They're going to breathe hard, they'll become tachycardic, and they'll become hypotensive and unstable. Now, adding PEEP. Now, this is one that we have to talk about. The reason that we need to talk about adding PEEP is because it sounds counterintuitive initially. The concept of adding PEEP to mitigate auto-PEEP will automatically sound counterintuitive, but it's a concept that actually has gained, that can be controversial, but physiologically it does tend to make sense when you kind of break it down. And when you consider a patient that may benefit from the addition of applied PEEP, the question you need to ask yourself is it truly an intrinsic lung property? Is the expiratory flow limitation created by an impediment in intrinsic properties of the lung that create expiratory flow limitation? So what you'll typically see, typically, you can tell this by the history of the patient. A lot of them are asthmatics, or they have COPD and they're on home oxygen. So that's a pretty big clue. Another clue comes from looking at the ventilator graphics. Rather than this nice smooth return of your expiratory flow to baseline, you see that you have a sharp rise, and all of a sudden it's like you hit a choke point, and your expiratory flow rate suddenly just drops precipitously. It drops precipitously, and it remains at this low flow rate for a fair amount of time. This can be explained by the concept of the equal pressure point. Now, equal pressure points occur basically when the alveoli that's expiring air along the airways, the pressure inside the airway drops to a point where the pleural pressure that surrounds it is equal to it. So beyond that point, the airways will collapse because the pleural pressure overwhelms the airway pressure itself. So typically in a normal breath, by the time that happens, you're in the bronchi and the trachea that are supported by hyaline cartilage so that they don't collapse. But here, they do collapse because the bronchiolar walls are very weak. Now, in someone with dynamic airway airflow obstruction, this choke point tends to happen very early during expiration because they just don't generate recoil pressure because of the extent of damage and inflammation in their lungs. So if we think about the waterfall analogy that was discussed by Dr. Tobin in 1989 in his paper that he published in Chest, he says that by applying PEEP, you can actually stent open these airways by essentially saying that the magnitude of the drop in pressure in the airway that is experienced at this choke point essentially is analogous to the height of a waterfall. And the height of that waterfall can be quantified by measuring your auto-PEEP. That's why it's important to measure the auto-PEEP. And that if you do not exceed the height of that waterfall, so if you do not exceed the auto-PEEP, then you level the playing field and turn this waterfall into a nice steady stream. But if you exceed the height of the waterfall, so if your auto-PEEP is 4 and you set your applied PEEP, you increase it by 6, you increase the entire height of the entire system, physiologically, meaning that you worsen dynamic hyperinflation. So that's kind of what Dr. Tobin meant when he said applying external PEEP to counter auto-PEEP. So lastly, talking about external PEEP, it minimizes the pressure difference across the obstructed airways, keeping the airways open, allowing airflow to progress naturally and allowing the lungs to reach their natural state of relaxation, thereby improving the work of breathing and the effort required to trigger the ventilator. But as mentioned before, you cannot exceed the height of the waterfall, otherwise you will worsen hyperinflation. Now, typically, let's say the auto-PEEP was 5. You don't necessarily want to match it by 5 because certain lung units are inhomogeneous, and maybe their waterfall is a height of 3, and another waterfall might be a height of 4. And while most of the waterfalls, meaning different lung units, have auto-PEEPs of about 5. So if you apply a modest rise, then you may be likely on the safer side. At the same time, ventilation is a dynamic process, and you still want to monitor your peak and your plateau pressures. And if you've increased your PEEP or your PEEP by a factor of like 3 or 4, and your plateau pressure rises in turn, you want to see it eventually kind of fall, or you want to see it stay the same. Otherwise, if your peak and your plateau are basically rising in concertion, then it could very well be that you're not making the difference that you wanted to make, and that adding PEEP to the system didn't lead to the desired result. Thank you, everyone, for listening to this talk.